This is part 2 of surgical infections, discussing cellulitis and specific surgical infections. Material is prepared by Professor Dr. Ahmed Farid, Professor of Surgery, Ain Shams Medical School. This is to remind you with the learning outcomes of the lecture. If you'd like to read them in details, please pause the slides. Cellulitis. Cellulitis is a spreading inflammation of connective tissue that is often due to beta-hemolytic streptococci. The invasiveness of this organism is due to the production of hyaluronidase. That is an enzyme that causes dissolution of the intercellular matrix, and streptokinase causing dissolution of the fibrin inflammatory barrier. Cellulitis may be accompanied by obvious inflammation of the draining lymphatics, that is lymphangitis, and the draining lymph nodes, that is lymphadenitis. There may be also associated septicemia. The treatment is immobilization with elevation, antibiotic therapy, and drainage of any residual pus formation or small abscesses. There is a group of patients who present with cellulitis of the lower limb, complicating lymphedema from any cause. There is usually no obvious entry site for bacteria. The cellulitis tends to be low-grade and browny in nature, and it is usually slow to recover to antibiotic therapy. That's because of the associated lymphatic insufficiency. Compression stockings are usually long-term measures, but recurrence is common. The clinical presentation of cellulitis includes local inflammation, redness, tenderness, warmth, erythema, and induration. Bacteremia is uncommon in healthy hosts. The borders are not well defined, and they are not raised as well. There may be lymphadenitis. Treatment is based on an outpatient treatment. No drainage is needed, only antibiotics, and best to give antibiotics that works on staphylococci. Staphylococci are the most common causative organisms. That is why the treatment could include dicloxacillin, macrolides, aztreonam, clarithromycin, ampicillin, clavulanic acid. Acute cellulitis is a locally spreading infection of the dermis and the hypodermis. It is facilitated, as we said, by the production of hyaluronidase and streptokinase. In limb infections, organisms draining towards lymph nodes can produce perilymphatic inflammation and painful red streaks along the limb, that is, lymphangitis. Regional lymph nodes react vigorously, becoming enlarged, painful, and tender. That is what we call lymphadenitis. This may also occur in staphylococcal infections. Highly invasive strains of Streptococcus pyogenes may cause necrotizing fasciitis, a deep-seated infection of the subcutaneous tissue that progressively destroys the fascia and fat with exotoxin production. Of course, this is not related to the two pictures, which is cellulitis of the right cheek and right periorbital cellulitis. A specific type of cellulitis is Ludwig angina. This is a life-threatening infection affecting the sublingual and the submandibular spaces. Serious infection with a high mortality that is due to the expected asphyxia because of the edema of the floor of the mouth. This can result from dental infections, which is one of the main causes. The most important treatment here is to do a release incision before asphyxia occurs. Now, this is a specific type of spreading infection that is called erysipelas. So erysipelas is a type of cellulitis, but it is characteristically a superficial type of cellulitis with lymphatic involvement. This is usually occurs from group A Streptococcus strains. It usually occurs following incidental minor trauma, insect bites. The lower extremities are most commonly affected. Empirical antibiotics is used for treatment, and they should act on streptococci. Clinically, erysipelas has an abrupt onset. It is important to notice that in erysipelas there is evident constitutional symptoms. There are high fever, chills, malaise, and nausea prodroma. This is usually followed by an area of red erythema with burning that develops over the next 2 days. The skin becomes red, shiny, hot, and the red area is sharply demarcated and it is raised. The sharp demarcation and the raised edge differs this specific type of cellulitis, which is erysipelas, from the other types of cellulitis. Vesicles and serous eruptions may occur when superficial skin necrosis occurs. Treatment of erysipelas is usually as an inpatient, especially if there is bullae or discharging inflamed skin. The treatment is principally penicillin G given intravenously. In severe cases, imipenem is used. Now to gas gangrene. Gas gangrene is a specific primary gangrene. The organisms are anaerobic, gram-positive, spore-forming bacilli that are usually present as fecal flora in the feces of animals. Characteristics of this infection: under anaerobic conditions, there is marked necrosis and gas bubbles in between the muscles and under the skin. It's marked edema, toxemia, and the toxin here is an exotoxin. Clinically, there is foul smell discharge, there is crepitus from the gas, and the skin is discolored. Clinically, the incubation period is about 3 days. Typically, the pain is out of proportion to the clinical manifestations. There is heaviness of the affected part, edema, brown discoloration. Then, when gas starts to form, crepitus will appear. There is a foul-smelling serosanguinous discharge, especially when the bullae starts to rupture. The vital signs may include systemic toxicity and include no or low-grade fever, tachycardia, which is a relative tachycardia, tachypnea, hypotension, or hypoxia. Confusion is evident with sepsis. A characteristic finding in patients with gas gangrene is seen in the X-ray, that is, gas in the X-ray. So you can notice the black color denoting the presence of gas within the infected limb. Treatment of gas gangrene includes the following. The patients should be isolated. The use of hyperbaric oxygen therapy is recommended. You should give the proper antibiotics. But the most important thing is the anti-shock measures, because, as we said, the constitutional symptoms, the general effects of gas gangrene infection is very serious. The removal of the necrotic tissue, what we call necrosectomy, and washing of the debrided wound with hydrogen peroxide is recommended. In patients with spreading gas gangrene, life-threatening amputation is urgently indicated. Anti-gas gangrene toxin, anti-gangrenous gas gangrene toxin serum infusion is given. Another type of specific infections is the necrotizing fasciitis. This is a standalone type of infection. It is caused by bacterial infection of the underlying fascia that spreads rapidly along fascial planes. Classically, it is Streptococcus infection, but most often polymicrobial, anaerobes, gram-negative organisms. Clinically, there is fever, pain. Locally, there is bloody blisters with marked leukocytosis in the blood picture. Septic shock can occur during debridement of the necrotic tissue. Necrotizing fasciitis is treated early by aggressive, extensive surgical debridement with systemic antibiotics and supportive IV fluids, nutritional treatment, with control of blood sugar if the patient is diabetic. The last type of specific infection is tetanus. Tetanus is an infection caused by gram-positive anaerobic bacilli, spore-forming. It produces an exotoxin that inhibits choline esterase at the motor end plate. The tetanus organism inhabits the fecal matter in animals, and the incubation period of the tetanus organism when it invades the body ranges from hours up to 3 weeks. Clinically, there is minimal infection process in the wound, so the wound does not look to be very markedly infected. However, tonic muscle spasm occurs all over the body. The spasm of the muscles will include the muscles of swallowing, so there is dysphagia, there is a locked jaw. The facial muscle spasm will give the characteristic risus sardonicus that you can see in the picture. Affection of the diaphragm will cause dyspnea. There is convulsions. Characteristically, there is no relaxation between the fits. There are fits, tonic fits, however, in between the fits, the muscles do not relax. Of course, there is fever, and this is a fatal disease. If it occurs, it will end finally with death. So, treatment of infected tetanus case should include considering putting the patient in a quiet surroundings to prevent provocation of the tetanic fits, isolation of course not to infect other patients, anti-tetanic globulin, which is the antitoxin, antibiotics, local wound care, and care of respiration to avoid the problems affecting the diaphragm, and of course muscle relaxants, trying to give muscle relaxants, however they are not very effective. Anticonvulsants can have a role, and those patients are usually admitted to the intensive care unit. It's most important to know how to prevent tetanus in a wounded patient. Vaccination is obligatory and compulsory. Now, all children are given the immunization against tetanus. A booster dose of the vaccine should be given. Whenever there are wounds in contaminated areas, there should be proper care of the wounds. Strict sterilization of instruments is important to to avoid transmission of infection through contaminated instruments. Anti-tetanic serum for the street wounds of non-vaccinated individuals was given. Now it's not used because all individuals are vaccinated. Tetanus toxoid for booster doses in children and in patients wounded in the streets is indicated or is recommended. Now, these are some of the important definitions that have been discussed with you before. Because they are important, please pause the lecture and read them thoroughly. That's toxemia, bacteremia, pyemia, and infection. Again, recall these important definitions of colonization, inflammation, sepsis, and septic shock. What's meant by irreversible septic shock, severe sepsis, and SIRS, which is the systemic inflammatory response syndrome. Finally, we will talk about bacteremia and septicemia. Spread of organisms into the bloodstream may be either as a transient bacteremia, which could be asymptomatic, or as septicemia with symptoms such as fever, chills, sepsis. It should be noted that critically ill patients may exhibit a systemic response due to cytokines and other biologically active molecules in the absence of positive blood culture. That is the systemic inflammatory response syndrome. Failure of multiple organisms in the presence of sepsis is referred to as severe sepsis. It is advisable to administer antibiotics when draining an abscess because of the associated sepsis and the risk of metastatic infection. That especially if the patient has a prosthetic device in situ or a damaged heart valve. Other examples of metastatic infections include portal pyemia with liver abscesses and systemic pyemia with widespread abscesses. A cornerstone in the management of infection in general. Please consider the following. Rest, improving the general condition. Start an empirical antibiotic after taking culture and change it according to culture if necessary. Improve and remove predisposing local causes for infection. Control diabetes, for example. Remove debris, foreign bodies, necrosis, and pus. Good wash by normal saline of the wound with avoidance of irritant chemicals. Avoid per-hole surgery in drainage, that is draining pus with a very small hole. Closure of dead spaces by packs or drains. Proper wound dressing in the technique and proper wound dressing as frequently as needed. Please be ready with your questions in the next face-to-face session. Thank you.